For the first paper, the topic is the relationship between left atrial appendage blood flow velocity, filling defects, and the risk of stroke by Dr. Takaharu Shimizu.
Thank you.
Please.
Thank you. It's my honor to be here to deliver my presentation, the relationship between left atrial appendage blood flow velocity, filling defects, and the risk of stroke. This is Virchow's triad, 3 famous causes of blood clotting. Atrial fibrillation, AF, is said to increase the stasis of the blood flow in the left atrial appendage, LAA, and can form thrombi in the LAA. According to a previous study, 17% patients with LAA blood flow velocities less than 20 centimeters per second had thrombi, as compared to 5% of the patients with higher velocities. So it can be said that the slower LAA blood flow, the more risk of stroke patients have. LAA blood flow velocity can be measured with a transesophageal echocardiography, TEE, and this method is most sensitive for detecting thrombi in the LAA as well. However, concerns about invasiveness have been raised. So a less invasive way of assessing LAA blood flow velocity would be beneficial for evaluating the risk of stroke. And filling defects on cardiac CT are thought to reflect the flow reduction. Here, we define filling defects as poor contrast enhancement in the LAA during the early phase of cardiac CT. Now, we hypothesized that some patterns of filling defects predicts high risk of stroke. And the aim of this study is to assess the relationships between LAA blood flow velocity, filling defects, and the risk of stroke. A thoracoscopic LAA resection was performed for 137 patients between 2014 and 2018. Preoperative cardiac CT was taken in each case. During CT scan, the ECG was recorded. And in the operating room, after the induction of the anesthesia, TA was inserted and LAA blood flow velocity was measured. Male was 106 and mean age was 68 years old. They were categorized into 3 groups according to the patterns of filling defects of preoperative cardiac CT. And these groups were compared with each other. Group A was a group of patients who had filling defects with a clear niveau, and the number was 31. Group B was a group of patients who had filling defects with an unclear border. The number was 38. And patients of Group C had no filling defects. The number was 63. And this is the relationships between filling defects pattern, AF, during CT scan, and LAA blood flow velocity. And patients who had AF during CT scan were 100%, 87.8%, and 31.5% in each group. This is significantly different. This result suggests that a clear border of filling defects has something to do with AF. And the LAA blood flow velocity of each group was 14.8, 15.9, 31.3 centimeter per second, respectively, with statistically significant difference. That is to say, the lower LAA blood flow velocity, the clearer the border of filling defects. These results possibly mean that AF induces flow reduction in the LAA, and the reduction appears as the clearness of the border of filling defects. This is the comparison in relation to the history of stroke. The prevalence of stroke in each group was 38.7, 31.5, 25.3%, and this is significantly different. As for risk factors, CHAS-VAS score was 4.0, 3.5, 3.3 respectively, without significant difference. On the other hand, Hasbled score was 3.1, 2.3, 2.2, and this has statistical difference. From the relationship between AF, filling defects, and LAA blood flow velocity, the results imply that AF slows LAA blood flow, and it appears as filling defects in cardiac CT. This agrees previous reports. In relation to the history of stroke and CHAS-VAS score, filling defects may be one of the risk factors of stroke, regardless of the score of CHAS-VAS. Actually, some previous studies suggested the usefulness of filling defect as a predictor of the occurrence of embolism in AF patients. The results of our study support these reports. In summary, when we evaluate AF patients' risk of stroke, it may be important not only to calculate CHAS-VAS score, but also to examine cardiac CT for their filling defects. That's all. Thank you for your attention.
I have one question to ask you that how can you explain why Hasbled score is different among these three groups of patients? Because your CHAS-VAS score no different, right? But Hasbled score different.
CHAS-VAS score, I think CHAS-VAS score has nothing to do with the flow velocity in the LAA. CHAS-VAS score can be calculated by heart failure or stroke history or something else. So CHAS-VAS score cannot predict the flow velocity in the LAA, I think. So that can cause the difference between CHAS-VAS score and filling defects, I think so.
How about the Hasbled score? That in your data significant different.
Yeah.
Hasbled, not CHAS-VAS score.
I can't explain the difference of Hasbled score, but I think Hasbled score can filling defects may be able to predict the risk of bleeding complication. I don't know, but maybe it is very important to assess the relationship between Hasbled and filling defect and bleeding complication, I think.
Please.
I think it could affect the Hasbled score because patients who before surgery have more comorbidities like renal function and hypertension, which you use to calculate Hasbled score. Patients with more of those, they have more chance of having AF. Same like the more unhealthy, the more comorbidities the patient has before an operation, the more chance they have of having postoperative AF after the operation. So I think it might be those two things which make the Hasbled score higher in patients who are more likely to have AF.
Okay, thank you.
Thank you.
For the second paper, the topic is anticoagulation or postoperative atrial fibrillation following cardiac surgery, a retrospective audit of 200 patients who underwent cardiac surgery at Greenfield between January and April 2019 by Dr. Henry Davis. Please.
Okay, hello, I'm Henry. So a bit of my background is I studied aerospace engineering originally, and then I studied medicine in China in Zhejiang University and a master's in cardiac surgery. And now I'm working back in the UK as a surgeon. Okay, so yeah, because there's a recent paper about postoperative AF and the higher incidence of postoperative AF than previously thought in non-cardiac surgery patients, and also the higher incidence of stroke in patients who are in postoperative AF as opposed to AF. I decided to do an audit into, it's a very large cardiac surgery centre in the UK, Glenfield Hospital, that does a lot of operations. So audit into whether patients who went into postoperative AF following cardiac surgery were anticoagulated or not. So the background is quite small here, but these are ASCVTS guidelines. And so there's class 2A recommendation for patients to be anticoagulated with unfractionated heparin or low molecular weight heparin between 12 and 48 hours after going into a new postoperative AF, post-cardiac surgery. So that's class 2A evidence. And then there's class 1 evidence that at discharge, patients should be on should have oral anticoagulation therapy until 4 weeks follow-up. These are other guidelines. Okay, so the objective was to look at anticoagulation status of patients being treated for postoperative AF in time from antiarrhythmic treatment to anticoagulant treatment. So the new papers also said that patients with more comorbidities going into going into cardiac surgery had more chance of going into a postoperative AF following. Like we know that sepsis causes postoperative AF sometimes, but also if people had more hypertension, renal problems, liver problems before, there's more chance that they would go into postoperative AF. So in the hospital in the UK, there's no guidelines on anticoagulation for AF. So yeah, we found 200 patients who had no history of AF before cardiac surgery, and then we looked at them from between January and April 2019. Then we identified those who went into postoperative AF by seeing those which were treated with amiodarone. In Glenfield, they always treat postoperative AF with amiodarone straight away. Then we looked to see whether they had no anticoagulation, prophylactic anticoagulation, or therapeutic anticoagulation at that time. Okay, so these were the results. From 200 patients initially, so at 0 hours, so from 200 patients initially, 44 patients went into AF, and initially, when they were treated with amiodarone, 40 of them had prophylactic anticoagulation, 5 had no anticoagulation at all, and just 2 had therapeutic anticoagulation. So it's 47 in total. Okay, so from 200 cardiac surgery patients, 47 went into new postoperative AF. And then at 24 hours, 3 of them were therapeutically anticoagulated. So 5 still had no anticoagulation, and 21 just had the prophylactic enoxaparin. And then this is 48 hours here. So at 48 hours, there were still 16 who were still in AF at 48 hours. 11 of them had prophylactic anticoagulation. 3 had therapeutic anticoagulation, and 2 still had no anticoagulation. So of the 200 patients, 47 went into a new postoperative AF. 1 patient from 200 had a stroke, but that patient was actually on therapeutic anticoagulation, but still had a stroke. And then there were no other strokes, and there were 3 AKIs with new AF, because that will affect whether they should have anticoagulation. So so only 10% of patients were anticoagulated according to ASCVTS guidelines at 24 hours. By 48 hours, 19% of patients had therapeutic anticoagulation. There was 1 stroke and 3 AKIs. So the conclusion was that in the hospital, they're not anticoagulating enough patients. It's only 10%, which is far below ASCVTS guidelines. So, so only 10% were anticoagulated. So we plan to put hospital guidelines in, but in the UK it takes a very, very long time to get hospital guidelines in. We planned to have re-audited it by now, but the delays in getting hospital guidelines mean that we are only just re-auditing now. But they will introduce hospital guidelines. So these are the evidence for the anticoagulation, so from cardiovascular surgery and Canadian Journal of Cardiac Surgery as well. And these are more of the evidence as well for anticoagulating at 12 and 48 hours. There's more evidence here. So this is the initial evidence that I showed before. And this is the guidelines that we had. So from the top right-hand corner, is the patient in a new AF since the operation? If no, then you don't need to anticoagulate. If yes, then is the patient still in AF at 12 hours? If yes, anticoagulate if bleeding risks are acceptable. So bleeding risk acceptable is decided by the team that did the surgery. Okay, then if you anticoagulate, you review at 4 to 6 weeks after discharge and look at their CHAD-VAS score to see whether they need to continue anticoagulation for life, or continue anticoagulation and refer to cardiology, or stop anticoagulation if they're now out of AF. Okay. Yeah, that's the end. So, any questions?
Any question? I have one question to ask that. You have one case that the patient has stroke, and that on anticoagulation already. This case on just only low molecular weight heparin or on warfarin?
They were on therapeutic dose of low molecular weight heparin. So they should have been fully anticoagulated, but they still had a stroke. So I'm not sure what the statistical significance of that is.
What about this patient body? Is a big guy or small guy?
He was, his BMI was normal. So, but he had a stroke, a severe stroke, and went to the, never really recovered.
Any relationship between AKI and prophylactic anticoagulant?
Yeah, so it's just that if they're in AKI, then they need anticoagulation more because the AKI can cause their hemostasis, the coagulation cascade to be even more severe and just more chance of having a stroke.
Any question? Yes, please.
I see this quite a comprehensive guideline for the AF patients. Is there any consideration of the LAA treatment? I mean, like some of our patients in the cardiac surgery, they have with an airway closure. So would that be consideration, like, sidelines of this pathway?
Okay, yeah, where it worked before in China, they would always close the LAA. But in the UK, they don't always close it, and that wasn't looked at in this, but that is something that would be interesting to look at in the future. In Hong Kong, do you always close it?
Yes or no. So some surgeons' preference would close, just like appendage. Whatever be possible, we close it. Some patients with a paroxysmal AF close it. In AF, definitely close it. So as you said, it's not a routine, but some will prefer to close anyway.
Yeah, in China they will close more than they do in the UK, but I'm not sure why that is.
Okay, thank you.
Thank you.
The next paper is 2 years result of left atrial cryoablation concomitant with mitral valve surgery via right minithoracotomy by Dr. Okamoto.
Okay. Thank you for nice Chairman. And I'm Dr. Kamoto from Japan. I'm gonna present the 2 years result of left atrial cryoablation concomitant with mitral valve surgery via minithoracotomy. I have no COI to be declared. So recently, we aggressively applied cryo-MACE procedure for minimally invasive mitral valve repair concomitantly. In this study, our 2 years result was reviewed retrogradely. The cohort includes 17 cases during May 2017 to December 2018. One mitral valve replacement was included, and the preoperative heart rhythm was Afib in 14 cases and proximal Afib in 3 cases. And my cryo-MACE using atrial cryoprobe is shown in video, and my typical MACE line is shown in the figure. Now I make a lines epicardially on the beating heart, and then I put a clamp and arrested heart. Then first I make a line from the free edge to the left atrial appendage. And then I make a roof line to make a nice PV box lesion. But still, there is some gap between the previous line. So then I put one more line between the 2 previous lines. Then I can make a good PV isolation line. Now after that, I make a line to the mitral valve annulus. Then I move to the epicardial coronary sinus line. So with these lines, I finished the left atrial lesion set. Then I make a mitral annular application to fix the mitral valve regurgitation. Okay. So as a result, we had no postoperative mortality and no major morbidity also. And at this surge, Afib was found in 2 cases. That means immediate recurrence. And pacemaker implantation due to the bradycardia was necessary. The latest checkup, sinus rhythm was kept in 12 cases. That means 70%. And addition to 2 recurrent Afib, our junctional rhythm was found, and also our pacemaker implantation was found. Okay, so although 2 proximal Afib was found during follow-up, but at the end, at the latest follow-up, these 2 cases were converted to the sinus rhythm. So in the echo data shows nice left ventricular and left atrial size reduction and improving wall motion postoperatively. Control of mitral valve regurgitation is acceptable, except for a case at 2 years. Freedom from recurrence of Afib was 85.7% at 2 years, which is identical to the previous another studies. And freedom from mitral valve regurgitation recurrence was 85.7% as well. And the table shows 4 cases with post-operative rhythm problem. 2 failure of sinus rhythm conversion and pacemaker implantation was happened during post-operative hospital stay. And another one pacemaker implantation was necessary a year after surgery. So I tried to find predictors of recurrence AFib, but it was not successful. So as a result, I couldn't find any good predictor of AFib recurrence in this study. So there was a lot of the same kinds of studies. So in a randomized trial, freedom from AFib recurrence was 63.2% at 1 year follow-up. And compared with this paper, our result was better or almost the same. But however, the problem of our study is absence of Holter monitoring in definition of AFib. I just checked the immediate ECG. So there was that's why my result was a little bit higher than this randomized trial. And also there was no difference between bilateral maze and the PV isolation in this paper. This study shows that low V1 wave, a history of AF longer than 10 years, and a larger diameter, larger than 70 millimeter, was a predictor of AFib recurrence. Recently, I studied left atrial clipping through the transverse sinus in right minithoracotomy setting. So left atrial appendage clip will be a strong prevention tool of stroke in AFib patient or paroxysmal atrial fibrillation cases, even in minithoracotomy approach. So this study has several limitations. And in conclusion, cryomaze procedure concomitant with mitral valve surgery via right minithoracotomy was an effective way in treatment of AFib. And our result of 85.7% of freedom from recurrence AFib was good compared with previous studies. However, any predictor couldn't be found in this study. So we have to continue the study for further. So minimally invasive heart valve and heart rhythm surgery might be very attractive for patients, especially in elderly patients. Thank you for attention.
Any question? You have 2 cases that
Yes.
transient AFib after the operation.
Yes.
What recurrence of AFib in both of these cases?
I cannot find a good reason of recurrence, but both cases, in both cases, the history of AFib was long, very long, probably longer than 15 years. And the left atrial size was over 55 millimeters. That was our reason.
But actually, transient AFib after the operation quite common, such as a paper from James Cook within 3 months is 38% relapse of AFib. That we call the blank period. And the second question is any relationship between severity of MR after the operation and the result of AFib surgery in your study?
Yeah, most of my cases were we don't make a MRR greater than moderate in immediate postoperative period. So you mean the preoperative MRR grade, no poster?
After the operation.
So usually after surgery, the MRR is trivial or mild. So
But in your presentation, you have some cases that MR 2+, right? In this group, any different of the outcome of AFib in your
No,
study?
I have only one moderate MR in, and also I found the MR moderate, greater than moderate MR was after 2 years of surgery. So probably that doesn't make any difference.
In my study, more than 390 cases of biatrial maze surgery. Some cases we accept that when we repair the valve and we check up by echo at 6 months, the result not so good. But the relationship in my study, no different between good repair and bad repair, no different outcome, different, not relationship at all between resolved mitral valve repair and AF surgery. Okay, thank you.
Thank you very much.
And then the last paper, the topic is concomitant atrial fibrillation ablation during minimally invasive mitral valve surgery is as safe and effective as in conventional approach by Dr. Daniel Tai Liang-Chan. Please.
Thank you. Good afternoon, ladies and gentlemen. I think this is quite a similar topic with Dr. Okamoto. So this is my disclosures. So just some brief background. As AF is very common with valvular heart disease, especially mitral valve. And we all know about the impact of AF, higher mortality for the patients, short-term, long-term, and also is very low chance of them back to sinus if we only deal with the valve itself. So the appendage, which is well documented by the concomitant maze procedures, so I'm not going to repeat that. But these are the reasons why the expert consensus in 2017 has upgraded the concomitant maze procedures as a class 1 indication in mitral valve surgery, aortic valve surgery, or even cabbage surgery. On the other hand, minimal invasive can be performed increasingly over worldwide. So we all know about the benefits from doing a small wound. However, there are less recommendation and also evidence concerning about doing the MIS mitral valve and concomitant maze. And even that might be a kind of a factor. Some surgeons may choose between the patients whether we do an open and maze for the patient or we just skip the maze and do the minimal invasive for the patient. So the simple objective is to compare our results, the midterm results of a maze ablation for those patients by a minimal invasive approach compared to those with a sternotomy approach. So this is the numbers we performed during 2013 to 2017, about 1,000 of a valve surgery. So about 37% of them have atrial fibrillation before the operation, which is quite high. And we performed concomitant maze in about 64% of them. So in this group, we just particularly picked those patients who have a mitral valve, a plus or minus tricuspid valve, and the concomitant maze. So there are two groups. In the MIS approach of the mitral valve with maze, there are 84 patients compared to a sternotomy approach in 101 patients. So for concomitant maze by the conventional approach, we mean that it's a full sternotomy, bypass support, and performing the Cox maze 4 procedures. Only some technical differences are the treatment of the ischemic lesion, the lesion set towards the mitral annulus. Some will perform by the clamp alone technique, or some of them will perform by a cryo probe. And the closure of the area, well, in the early cases, it's by the sutures, and the later on, we'll use the standard clip. For the concomitant maze in the MIS approaches, so this is my approach, a little bit different with Dr. Okamoto. So my camera's on the head side, and we will open up a 4 centimeters working port, mostly non-rib padding, either assist by the endoscope or by the robotic assist. So I won't show in detail. So the lesion size is according to the Cox maze procedures, which is quite similar to a previous speaker. And also the closure of the appendage, all of them, most of them, I would say, is by the clip. So after the procedures, we will prescribe amiodarone. It's not contraindicated, which means that the heart rate is too slow. And then we follow up with clinical and the ECG and intermittent of echo assessment as well. So the definition of success, we adopting the common consensus approaches. We have 3 months blank period, so any kind of a AF during that period, we will skip that. And then we will have a sinus rhythm at 1 year documented by a Holter at the 24-hour Holter's documentation. So these are the results. So again, for the MIS concomitant MACE, there are 84 patients. 101 of them performed through the conventional sternotomy approach. The mean follow-up time in this cohort is 44.7 months. So first, the preoperative data. Comparing the two groups, they are quite similar, but you can see that for the sternotomy group, they are overall a little bit older. That is the reason why we usually perform the minimal invasive approach for those younger patients. The ejection fraction is a little bit lower for those group for those undergo sternotomy approach. And otherwise, you can see the preoperative risk scoring is quite similar among the two groups. And also for the AF and the echocardiogram characteristic, the mean AF duration is quite similar among the two groups. Most of them are long-standing persistent AF, followed by persistent AF. Just a minority of them are paroxysmal AF. And the LA is dilated. About 1/3 of them is rheumatic disease. That is the reason why we have quite a substantial amount of mitral valve replacement in this cohort as well. So the bypass time and cross-cam time is significantly shorter in the conventional group, which is logical. So with that background, these are the in-hospital results. For mortality, it's quite similar. The other major comorbidities are not significantly different. There are 1 in the MIS group have a pacemaker, 3 in the sternotomy group have the pacemaker inserted. So this is the key primary objective of this study, presenting the 1-year results. So all of the patients, except those have been died in hospital, they reached the 1-year follow-up with the 24 hours Holter assessment. So there is no added mortality or no added major complications in the MIS group. There are 2 non-cardiac deaths in the sternotomy approach, but their clinical results is no statistical significant difference. So the overall sinus rhythm at 1 year is about 85% in the MIS compared to 88% in the sternotomy group. So we adopt the presentation of a sinus rhythm without anti-arrhythmic drug. So in the MIS group, it's about 82% compared to sternotomy group, around 85%. Also, it's not statistically significant. So with the follow-up results, so at the latest follow-up, so this is the actuarial survival with an AF3 at about 18 months. The overall cohort is 68%. So when we break down into a sternotomy group and the MIS group, we take at the 60 month, the actuarial AF3 survival has no difference between the two groups. It's about 69% in sternotomy group compared to 65% in the MIS group. So this is some additional information. It's about the risk factors for failing of the MACE. We'll take the whole cohort as an analysis. We put into a multivariate analysis using the survival statistics analysis. So this is the 2 factors I can identify that the AF, and I mean the MACE was failed in the follow-up. One is a large LA size. Second is the older age, which is older than 60. Other than that, the duration of the Afib or the procedure per se hasn't made any difference on the effect on the success rate of the MACE procedures. So up to conclusion, is a concomitant AF ablation during MIS mitral valve surgery is as safe and as effective as in those patients performed by sternotomy approach. Although MIS approach takes longer bypass and cross-cam time, there are no difference in their morbidity and mortality. Rhythm success rate at 1 year and the midterm follow-up success rate was quite similar between the two groups. So concomitant MACE procedure should be performed during MIS mitral valve surgery approach, or it should not be an exclusion factor for patient to undergo minimally invasive approach. Thank you for your attention.
Okay, thank you. Any question? I have several questions. The first thing, you divide your patient into groups as a randomized or non-randomized at all.
The randomization is basically by surgeon's preference.
Okay.
So we have
different
five
on-
surgeons. Yeah, we have five surgeons in our center performing MACE procedures. So mostly me and another surgeons will perform minimally invasive. But the case was randomized. So that's why it's randomized by surgeon's preference.
And before you stop anticoagulant, did you perform Holter monitor to the patient before stop anticoagulant?
That's a good question. So it's a very complicated formula. So if the patient is, one group is that they have replaced the valve, so they will go on anyway because of the mechanical prophysis inside. But for those patients have a repair at the 3 months time period, if the patient is having a clip, so usually we will just switch the anticoagulation to a lower strength, not using the Coumadin or using the warfarin, because we trust the effect of the clip with the LA closure. So we would have a tendency of early taking off of the anticoagulation.
So you would not perform Holter before you stop?
No, usually the Holter perform around 1 year after the surgery.
But I advise you to do Holter before you stop the warfarin. The reason, because in my study, the patient who is in sinus rhythm, and my protocol at 6 months, I perform Holter monitor. And you know, not 100% of the sinus rhythm patient, Holter monitor, no Afib, is just only 87%. So it means that 13% is the silent Afib. So it's safer to the patient to perform the Holter before we stop.
Agree.
And I have one question or two questions. You have long-term follow-up at 7 years. How many % of complete follow-up? Number of cases?
It's almost 100%. It's 90% at most, because only a small proportion of the patients is coming from outside Hong Kong. So within Hong Kong, all the follow-up system is connected by the central computer system. That's why the clinical, electronic system. That's why all the data can be retrieved.
My last question, in the sternotomy group, you use the cryo when compared to bipolar. Cryo just only 12 and bipolar 89. Why so much different?
I would say there is some effects on the, as I mentioned during the presentation, is the lesions from the box lesion to the mitral annulus. Because in the past, because of a reimbursement issue, we cannot open the bipolar probe and the cryo probe. That's why we use so-called the Banuzzi technique. So we use a bipolar probe clamping on the annulus. And it is well known that it's not so effective as the lesion performed by the cryo probe. So that's why I believe that might be the reason using this technique, the success rate is a little bit lower than using the cryo.
Do you do the reduction technique when it's huge left atrium, such as more than 6 centimeter or 7, and you have the cut off that more than 7 centimeter in diameter, not perform the MACE operation? You have the...
We don't. So we just perform for all patients unless we found some increased risk, like unexpected adhesion or the patients doing unwell. So that is the reason we will skip the MACE. Otherwise, we perform for all patients.
Thank you. Any question from the floor? If not, I would like to close the session. Thank you, everyone.
Thank you.